Good evening, everyone. I'm Dr. Vaibhav Watts, and on behalf of Roche, it's my absolute pleasure to welcome you all for today's scientific meeting on HER2-positive early breast cancer. As the title suggests, HER2 matters, from control to cure. The ABC space has been rapidly evolving with the ongoing advances in therapies, new data readouts, and trials showing the OS benefits. And talking about innovation, PESGO has revolutionized the HER2 treatment, putting patient centricity and convenience to the core. It's an honor to have such an esteemed faculty with us. We are fortunate to have Dr. Mark Verrill from UK to share his experiences too. It does make a perfect recipe for the discussion. So today's meetings gives us a valuable opportunity to share insights, challenge assumptions, and reflect on how we can better translate data into practice for better patient outcomes. To kickstart the proceedings, I would like to invite our chairperson for today's meeting, Dr. Poonam Patil. Ma'am is a leading medical oncologist at Manipal Hospital, Bangalore. With over 35 years of experience in cancer care, Ma'am specializes in gynecological and women's cancer, expertise in chemotherapy, immunotherapy, targeted therapy, and precision oncology. Ma'am is an alumni of SMS College Jaipur and Kidwai Memorial Institute, has been actively involved in clinical research with over 20 publications. Dr. Patil is a member of ASCO, ASMO, ICON, and many other oncology bodies. Ma'am is a strong advocate for early cancer detection. She frequently engages in public education, awareness campaigns, and national health initiatives. We are fortunate to have you, ma'am. Over to you to please start the meeting and also invite Dr. Mark.
Thank you very much, Dr. Vaibhav and Roche, for having us here today. And it seems to be an exciting topic. HER2 matters, from control to cure. And I'll just set the ball rolling. Can I please have the slides? Yes. Next slide, please. Next slide, please. These are the disclaimers. So as we know, the epidemiology of breast cancer, it's one of the most common malignancies amongst women globally. And now close to lung cancer as the leading cause of global cancer incidence in 2022, with an estimated 2.3 million new cases, representing 11.5% of all cancer cases. In India, it's the most common cancer seen in women, and the incidence is around 2 lakh patients per year, as the Globocon 22 data tells us. Next slide, please. The prevalence of HER2 positive breast cancer in India ranges from 11 to 17% and is often associated with a younger age at diagnosis and more aggressive tumor biology. HER2 positive breast cancer is associated with a higher proliferative index, increased risk of recurrence, and historically poor prognosis in the absence of targeted therapy. And that is when the revolution came. Next slide, please. When we had trastuzumab in the care of HER2 positive breast cancer patients. Next slide, please. So the trial which showed that trastuzumab works well and the results that it gives us impacts the overall prognosis, and we could even predict the future prognosis, was the NOAA trial, in which the patients received neoadjuvant chemotherapy with trastuzumab and without trastuzumab. And as you can see here, the first one is breast pathological complete response, and the second one is total pathological complete response, which included the breast and the lymph nodes as well. And you can see what a marked difference in the pathological response the addition of trastuzumab made to the patients. 43% with addition of trastuzumab and 22% without trastuzumab in the breast. And as we know that in axilla, the number is a little lesser because nodes don't respond as much as the breast tissue responds. There also, we have 38% in trastuzumab group and half of them only in the trastuzumab, without trastuzumab group. Next slide, please. So this showed us that the pathological CR also impacts the event-free survival and overall survival. And you can see here that patients who received chemotherapy plus trastuzumab and see the patients who did not receive trastuzumab, see the curves. There is a remarkable gap. There is a big gap between the two curves, and implying that trastuzumab won hands down in both the settings. Next slide, please. So studies show that neoadjuvant treatment with, now that we know that PAT-CR is so important, studies showed that neoadjuvant treatment with pertuzumab and trastuzumab when added to chemotherapy resulted in a higher PAT-CR rates versus trastuzumab plus chemotherapy. So we had one step up now, and these are the various phase 2 and phase 3 trials in which trastuzumab was added with pertuzumab, and it showed that there were more number of patients who achieved PAT-CR. You can see these are the trastuzumab studies, and these are the pertuzumab and trastuzumab studies. Next slide, please. There was also pooled analysis which was presented at SABS in 2019. And here what they did was they pooled the patients who received pertuzumab and trastuzumab both as neoadjuvant, adjuvant, and or adjuvant only trastuzumab. But neoadjuvant pertuzumab was there in both the scenarios. Next slide, please. And what this told us that dual anti-HER2 therapy with pertuzumab and trastuzumab resulted in a lower risk of recurrence compared to trastuzumab alone. And patients receiving trastuzumab, pertuzumab in both neoadjuvant and adjuvant settings had the best event-free survival. Even when adjuvant therapy was de-escalated to trastuzumab, pertuzumab, followed by only trastuzumab, especially in patients who had achieved PAT-CR, they also did very well. So next slide, please. So that is where we know the importance of pertuzumab being added to trastuzumab in the chemotherapy and targeted therapy armamentarium. So the patients, however, were receiving earlier intravenous pertuzumab, and the process of receiving, and trastuzumab also, the process of receiving IV infusion therapy places a significant burden on the entire life of the HER2 positive breast cancer patient and her family and friends. You know, especially in India, breast cancer is not a disease of the patient only, it's a disease of affecting the entire family. Patients try to maintain a positive view towards IV infusion therapies because of their gratitude towards and belief in the potential life-extending or life-saving benefits of their treatment. But when they were actually taken into confidence, the survey showed that there was significant burden on the lives of HER2 positive patients. And this could be divided into 4 categories: the logistical and time burden of attending appointments, the physical pain and discomfort of infusion, the support required of friends and family, it obviously took a longer time, and the consequent emotional impact of these burdens. So the nature of this burden differs depending on the stage at which they are in infusion. If it is an early disease or if it is a metastatic disease, the treatment goes on for a long time, and their own life circumstances, how their family circumstances are, and the support available to them prior to and during the treatment. Next slide, please. So what is the mechanism of action of pertuzumab, trastuzumab? We have a fixed dose combination of pertuzumab, trastuzumab known as FESGO, and this is given subcutaneous, and it combines pertuzumab, trastuzumab, 2 monoclonal antibodies with recombinant human hyaluronidase. Pertuzumab is designed to work with trastuzumab for a dual HER2 blockade. In preclinical models, pertuzumab targeted different subdomain on the HER2 receptor than trastuzumab to block the dimerization with HER1 and HER3 receptors and provide a dual blockade of HER2-driven signaling pathways. Hyaluronidase is an endoglycosidase enzyme that is used to increase dispersion and absorption of co-administered drugs when administered subcutaneously. It allows subcutaneous delivery of large drug volumes. It increases permeability of the subcutaneous tissue, and the subcutaneous tissue is restored within 24 to 48 hours. What it means that the effects of hyaluronidase are reversible and permeability of the deploying hyaluron based on the preclinical studies. Next slide, please. So this is what a cartoon showing the impact of recombinant human hyaluronidase on the subcutaneous injection of large fluid volumes. So the subcutaneous layer contains a matrix of the hyaluronan fibers and collagen fibers, because of which we can't give more than 1 ml otherwise subcutaneous administration. But when we add hyaluronidase, you see that how the fibers are temporarily and locally degraded because of the hyaluronan, and there are no changes in the structure, providing macromolecules, collagen and elastin. So it is just a temporary and local change. And this results in a temporary increase in the local subcutaneous dispersion area, enabling larger volumes of fluids to be administered. After a subcutaneous administration dose, the architecture of the skin is reformed within 1 to 2 days due to rapid clearance of the hyaluronidase and fast hyaluronan turnover. So this formulation of pertuzumab and trastuzumab with this recombinant human hyaluronidase allows subcutaneous administration of volumes larger than 1 ml as well. Next slide, please. So this is again a figure to show you that if you do not give recombinant hyaluronidase, this is what happens. You can see here the two figures, that before infusion, how the bleb occurred. And the second one was when with the recombinant human hyaluronidase, there's absolutely no change which is seen. Next slide, please. Yeah, so I think that is my last slide. Yeah. So thank you. I now invite the next speaker for the day, Dr. Mark Werrell. So he shall be talking about his experience at NHS and moving towards cure in HER2 positive early breast cancer. Dr. Mark Werrell is a consultant medical oncologist at the Northern Centre for Cancer Care, Newcastle upon Tyne, UK. He is the medical oncology clinical lead for the national audits of primary and metastatic breast cancer. And after studying medicine in the University of Cambridge and University College London, he completed his training in the very well-known Royal Marsden Hospital and the Institute of Cancer Research. Over the last 25 years, he's been in Newcastle and has undertaken numerous management and leadership roles. He has a proven track record in breast cancer clinical trials, leading to multiple publications, which we have all read, Dr. Mark, and we are very happy to have you here amongst us today. He has more than 1,000 patients in clinical trials, more than 500 patients in randomized breast cancer trials, more than 50 peer-reviewed publications, and has delivered more than 100 lectures in over 40 countries as an expert. Extremely happy to have you, sir, today. Dr. Mark Werrell, please.
Thank you very much for that very warm introduction. So I'm just going to try and share my slides. Okay, so over the next half an hour or so, what I hope to share with you is how we've applied some of the data that we've just heard into our routine clinical practice in HER2 positive early breast cancer. And this is based on my experience working in the Northern Centre for Cancer Care in Newcastle. These are my disclosures, which effectively all relate to companies active in the field of breast cancer. So we have a challenge in early breast cancer, which is always to strike a balance between eradicating cancer and avoiding overtreatment. And there are numerous examples over the years where we've started by throwing everything at the cancer. And then over time, we've said, actually, we don't need to do quite everything and we can de-escalate treatment. And I hope to be able to illustrate some of the ways that we can do this in HER2 positive breast cancer. And it all really started about the end of the last millennium, really, when we first saw the data on the remarkable activity of trastuzumab in metastatic breast cancer, and then 20 years ago, the first publication of the adjuvant data. And I still remember as if it was yesterday being in a joint session at ASCO in New Orleans that we didn't know was happening when we traveled out to the meeting, when these two North American trials, NSABP-B31 and NCCTG 9831, and a European trial called HERA that we were an investigating center for, presented their data on the adjuvant use of trastuzumab. And this is one of the later updates with a median time on study of 8.4 years, showing a reduction in the risk of death by more than 25% and a reduction in the risk of recurrence of 40% with the addition of trastuzumab. And one of the things that strikes me about this is we first used trastuzumab in early breast cancer in the adjuvant setting. The NOAA data that we saw presented in the previous presentation was 5 years later. So everything's flipped round now. We don't do an adjuvant study and then see if the treatment will work in the neoadjuvant setting. We do the neoadjuvant first. And the aims of neoadjuvant treatment are, of course, to downstage locally advanced disease to make it operable. And again, when I moved to Newcastle more than 25 years ago, that was the only time the surgeons would let me see a patient and give them drug treatment first. We then moved to downstaging larger operable cancers to facilitate breast conservation and potentially de-escalate auxiliary surgery. But again, that was still driven by surgical desire. And the surgeons were also fond of allowing time for genetic testing where it would alter the surgical plan. And it's really the bottom two now. So the evaluation of clinical and pathological response to treatment to inform adjuvant therapy, and the unique, I think, role of neoadjuvant chemotherapy in breast cancer as a scientific platform for translational research that have driven more contemporary efforts in the field, and why I think as a medical oncologist it's such an interesting thing to do. Neoadjuvant early breast cancer studies have a primary endpoint of PCR, as we've already heard, and of course that's available in months rather than having to wait years for adjuvant data. Because you get the answer, PCR or not, it's binary, you can use much smaller sample sizes, typically hundreds of patients compared to the thousands needed in adjuvant studies. And because we're treating the patient with the tumor in situ, we can do serial imaging and biopsies to look for real-time evidence of benefit of chemotherapy. So in the neoadjuvant setting, we know the treatment's working because you see the tumor shrinking, you look at the pathological response. And when patients ask me in the adjuvant setting, how will I know when the treatment has worked? The only real answer is you'll only know when you die of something else rather than the breast cancer. So you can see what's going on. Clearly, we get some short-term safety data that require longer-term confirmation and bigger numbers, sometimes in the post-marketing setting. But we have this ability to identify patients with increased and decreased recurrence risk. So this is kind of a hierarchy of the patients that we want and don't want to treat. And the patients who do the best with neoadjuvant treatment are estrogen receptor negative, HER2 positive cancers on the far right of this slide. That's my favorite group to treat, followed by triple negative. And then ER positive, HER2 positive patients do pretty well with neoadjuvant treatment. But on the far left, the ER positive, HER2 negative patients don't respond very well to neoadjuvant treatment. They may not need chemotherapy at all, so why give it? And I'm certainly increasingly resistant to treating this group. But the key that makes all of this so interesting is the ability to link neoadjuvant pathological complete response to longer term outcomes. So if you're quite patient, disease-free survival or distant disease-free survival, and if you're very patient in the adjuvant setting, overall survival. So we can show that tumors that or treatments that improve the PCR rate will lead to improvements in these longer term outcome measures. And one of the challenges is to define the relationship, the numbers. And there's some work, although I'm not going to present it, that started to look at that. We knew this really from Patricia Cortazar's work on behalf of the FDA in the United States. And this is just the association of PCR with ER and HER2 status. So in the hormone receptor positive HER2 negatives in the left panel there, the PCR rate with chemotherapy is about 10%, slightly higher if you select on biological features like Ki67 or multi-gene assays. And there is a close association with event-free survival with a hazard ratio of 0.49, but it's a group of super responders who get the PCRs. In the hormone receptor positive, HER2 positive space, in Cortazar's work, the PCR rate was about 30%. Many of these patients actually didn't receive trastuzumab as part of their neoadjuvant treatment. And you see again an association of PCR with outcome with a hazard ratio of 0.58. But I think the feature of the ER positive patients is that we're going to add in a very important part of their therapy after surgery. So these are people who haven't had endocrine therapy, which we know is of critical importance in ER positive patients. When you then look at the hormone receptor negative patients, so hormone receptor negative, HER2 negative, conventional chemotherapy PCR rates of 35%. Obviously, we know from more recent trials that these numbers go up with the addition of platinum and then pembrolizumab. And in the HER2 negative, sorry, hormone receptor negative, HER2 positive space, again in Cortazar's data, PCR rates of 40%, but as we've seen already this afternoon, much higher rates, probably over 60% would be our expectation now with chemotherapy and dual antibody therapy. So this is a case where we've applied this. This was a 22-year-old who presented to her GP with a lump in her breast. Initially, as usual with a GP, it was felt it was probably benign, and she was seen in the cancer center with a right-sided retroalveolar mass with tethering to the nipple, which is immediately clinically suspicious. No palpable axillary lymphadenopathy. And you can see on her mammogram, you've got this mass close to the skin. You see it again on this projection, and this is it after it's had its clip put in, localization clip put in, and this is the rather more florid appearance on MRI. Core biopsy showed an invasive ductal carcinoma of grade 3, ER positive with an all-red score of 6, and HER2 positive 3+ on immunohistochemistry. Now, I'm just going to flag the Neosphere trial because the Neosphere trial was the first study that looked at the combination of pertuzumab and trastuzumab with chemotherapy. And it essentially looked at docetaxel as the chemotherapy and tested all of the available combinations. So at the top, trastuzumab and docetaxel with a PCR rate of 29%. Second down in green, pertuzumab, uh, trastuzumab and docetaxel, so the dual antibody therapy with a PCR rate of 46%, and then a non-chemotherapy regimen, Herceptin and Perjeta, PCR rate 17%, and then at the bottom, pertuzumab and docetaxel, PCR rate of 24%. And I think the important thing to remember about this was a window of opportunity study, just 4 cycles of treatment, and we still see this very satisfying 46% PCR rate, and that translated into a longer term overall survival effect. Other trials were running about the same time. Trifena, we've seen the results of that. That was the first trial to use the non-anthracycline containing docetaxel and carboplatin chemotherapy regimen with concurrent pertuzumab and trastuzumab, and produces numerically the highest PCR rate, although it's not statistically significantly different. And again, the Berenice trial used a full year of dual antibody therapy, either preceded by FEC and then docetaxel, pertuzumab, trastuzumab, or dose-dense AC and weekly paclitaxel. And you see in both arms of that trial a PCR rate in excess of 60%. And I show that because we were one of the investigating centers. And then importantly, the Federica trial design, that was a randomized choice essentially based on the Berenice trial design that used either dose-dense AC followed by Paclitaxel or conventionally dosed AC followed by docetaxel, and patients were randomized to receive their pertuzumab and trastuzumab using the fixed dose subcutaneous combination that we've heard about, or conventional intravenous treatment. And the endpoints were at the time of surgery, first of all, looking at pertuzumab serum C trough level at pre-cycle 8, and secondly, looking at the non-inferiority for trastuzumab to check there wasn't an interaction, and total PCR rate with follow-up beyond the end of the study. And this enabled us to start using subcutaneous formulation in the neoadjuvant setting. So this is just a quick run through the endpoints. So the primary endpoint was pertuzumab and trastuzumab IV versus subcut, geometric mean C trough level prior to the final cycle of treatment. And you can see that it's a little bit higher in the fixed dose combination. And that probably reflects the higher dose of pertuzumab in the subcutaneous formulation, 600 milligrams compared to the IV dose of 400 milligrams. And you see the same pattern with trastuzumab, which again, IV is dosed on a per kilogram formula calculation, but in the subcut, it's the fixed dose. And then PCR rates. So the PCR rate in the two arms of the study were touching 60% and were basically identical, although of course statistically it's impossible to ever prove that two things are the same. So our patients or commonly used regimens would be EC in Europe, AC in the States, followed by docetaxel or weekly paclitaxel, or this TCHP with a carboplatin in there. I tend to favor the anthracycline containing one, not because TCHP doesn't do very well, but I'm a little bit wary in the borderline HER2 expression. So the patients with 2+ overexpression on IHC who are only just over the bar for positivity on gene amplification. So as I say, I'm a bit wary of TCHP unless they're very strongly HER2 positive, and then surgery at the end of time. We use all subcutaneous. We don't use any intravenous pertuzumab and trastuzumab now. And we give an extra bridging cycle before surgery. So even in ECTPH, patients are receiving 5 doses of pertuzumab and trastuzumab before surgery. And then we work very hard in collaboration with our surgeons to ensure that patients get their surgery in that 4th week after the last chemotherapy. And it works very well if you maintain communication. This is just a reminder of the patient's baseline MRI, and after their neoadjuvant chemotherapy, the tumor had completely disappeared, and that was borne out pathologically with a complete pathological response. They couldn't find the clip actually, but they assumed the tumor bed had been excised. We x-rayed the patient, the clip wasn't in the patient. I think it was probably somewhere on the floor in theaters, but she had this pathological response. The other thing that was really important was looking at the lymph nodes. And although at the start we didn't believe the nodes were involved, it was important to check for features of regression in the nodes because our approach to adjuvant treatment differs slightly based on whether or not there are any evidence ever of involved lymph nodes. So with her PCR and without there ever having been evidence of axillary lymph node involvement, she then went on to receive subcutaneous trastuzumab as our preferred adjuvant treatment in the node-negative PCR state. And again, I'm sure I don't need to rehearse the time advantages in particular and the overwhelming patient preference for subcut versus intravenous. So moving on to the next case, another young woman who presented to a GP with a breast lump that was again initially felt to be a fibroadenoma. She had a 5 centimeter mass in the upper inner quadrant of the right breast, which was mobile, no palpable axillary lymphadenopathy. But on an MRI scan, you can see this bilobed tumor in the inner part of the right breast. And there's also an axillary lymph node, which on a second look ultrasound was biopsied and proven to contain cancer. It was another invasive ductal carcinoma of grade 3. All red score on this one was 7 out of 8, and it was positive 3+ on immunohistochemistry. So she received the same ECTPH induction treatment, And this is a reminder of her pre-treatment MRI and another radiological CR, so no radiological evidence of disease after chemotherapy. But she had a somewhat different surgical outcome. So there was a tumor bed with no residual invasive carcinoma. There was, however, extensive DCIS remaining, and it's important in patients where there is DCIS that you remember to do a mammogram as well as an MRI at the end of treatment. Obviously, we couldn't retest the receptors because all the cancer was gone, and there were no lymph node metastases seen in 0 of 15 axillary nodes, with features of tumor regression in 6 of the nodes. So we considerably downstage the axilla, but we saw the features of the tumor that had been there. So in this case, we rely on the affinity trial to select our adjuvant treatment, and this is the most recent update of affinity presented at ESMO Breast just 2 months ago by Sibylle Liobel. And this was a randomized trial of adjuvant treatment, so surgery first, central confirmation of HER2 status, and patients were randomized to chemotherapy with trastuzumab and pertuzumab, or chemotherapy with trastuzumab and placebo. It was a big trial with 10 years of planned follow-up, and the primary endpoints were invasive disease-free survival. So if you look at the numbers, there were 4,800 patients randomized, making my point, I think, about the size and the length of follow-up that you need in an adjuvant study. Just looking at some of the highlights of the trial, nodal status. Sorry about the dog. So nodal status, around 2/3 of the patients were node positive. The majority had 1 to 3 nodes. The majority of patients received an anthracycline containing regimen rather than the non-anthracycline containing THP regimen. And around 2/3 of patients were ER positive. So very much as you would expect. So this is the ITT, invasive disease-free survival, with a median follow-up of 11.3 years. And you can see at the 10-year time point, there's a 3.4% difference between the pertuzumab and placebo-containing arms, with a hazard ratio of 0.79, which is statistically significant. And then we see the number of events, so 300 events out of the 2,400 patients receiving pertuzumab, 379 in the patients receiving just trastuzumab, and the majority of those are distant recurrences. But note, there's no difference in the rate of CNS recurrences, a modest reduction in the number of local regional recurrences contributing to the overall delta. And there were no meaningful differences in the number of contralateral breast cancers and no difference in the number of deaths without a prior cancer-related event. When you then start to dig down into the detail, this is the overall survival analysis, and you can see a hazard ratio of 0.83. The confidence intervals just touch on unity, and the p-value was 0.0441, which just crossed the pre-specified p-value of 0.496 required for statistical significance. So in the ITT population, there is this modest but statistically significant overall survival advantage. If you then cut down by subgroups, node positive versus node negative, you see an overall survival difference of 2.7% in the node positives compared to 0.2 in the node negative patients. I think people widely take this to inform their treatment and suggest that pertuzumab isn't necessary in lymph node negative patients. And then this is by ER status. And interestingly, in the earlier cuts of the data, there appeared to be a bigger advantage in the hormone receptor negative patients. In this most recent cut, there's a slightly bigger advantage in the hormone receptor positive patients. So I think you have to say nodal status should inform your treatment rather than ER status. And then this is just the overall treatment effect. This is node positive versus node negative. And then this is node positive, ER positive, node positive, ER negative, node negative, ER negative and node negative ER positive. So you see most of the difference is in those node positive patients, with the biggest difference in the hormone receptor positive group. Bear in mind, it's not statistically different. And then cardiac events, there were additional cardiac events in the pertuzumab containing arm, but the event rate was very low, and there was no excess of cardiac deaths when pertuzumab was added into the treatment. So in our patient who had proven axillary lymph node involvement and regression seen in the node, she then moved on to she moved on to intravenous pertuzumab and trastuzumab because it was before the subcutaneous formulation was available, and that was in April 2021. So if she was coming through the door now, she would get all subcut pertuzumab and trastuzumab, and that would continue for the remainder of a year after her intravenous chemotherapy and surgery. So finally, I want to present the case of a 70-year-old who had a symptomatic breast lump seen about the same time as the other two, a 4-centimeter mass in the breast, and in this case, palpable lymphadenopathy. So this is the mass in the breast, and these are the axillary lymph nodes. Again, she went on to ECTPH, and again, like the other patients, post-treatment, she had a complete response on MRI, but she had a significant burden of residual tumor. So she had invasive ductal carcinoma, NST grade 2, measuring 24 millimeters. There was DCIS taking the total size up to 45 millimeters. There was a partial response to treatment, so more than 10%, but less than 50% of tumor remaining. We rechecked the ER and HER2 that remained positive, and she had 8 involved axillary lymph nodes microscopically, or under the microscope. 7 were macromets, 1 was a micromet, and they all had some features of tumor regression. So clearly we're less happy about this. And if you want to quantify the excess risk of recurrence with residual disease, you can use what's known as the RCB index that was published by Fraser Simmons and his group from MD Anderson back in 2007, and looked at the variables here: primary tumor bed dimensions, cellularity fraction, size of the largest metastasis, and the number of positive lymph nodes, and fed this into the RCB formula that you can see here, and came up with numerical groupings. Now, I don't know anybody who does this because PCR itself is such a potent prognostic factor. But you can show that the more residual disease you have, particularly if you have RCB3, you can see that the prognosis is just worse and worse and worse. And this is patients who'd received just trastuzumab with an anthracycline and taxane. And even the group of patients with a modest amount of residual disease do far worse than the patients with PCR. So if you want to select patients for escalation, you should use PCR, not the volume. So what can we do in those patients? Well, we might want to escalate treatment. So rather than give trastuzumab on its own, give trastuzumab with a pegged-on cytotoxic as an antibody drug conjugate. And this is the structure of Kadcyla, which uses the trastuzumab monoclonal antibody with a stable linker that allows you to stick the cytotoxic DM1 or emtansine to it. And that's attached with a ratio of 3.4 emtansines to each trastuzumab antibody. And TDM1 was tested in patients who had neoadjuvant chemotherapy with at least trastuzumab. They were able to have an additional anti-HER2 therapy, had surgery, and had any amount of residual disease. And those patients were randomized to Kadcyla or to continued trastuzumab. So just looking at some of the demographics, these patients had quite a high stage at presentation. A quarter of them had inoperable disease. Most of them, so 80%, only had trastuzumab as a targeted therapy. Just under half were node positive after neoadjuvant therapy. A fair number weren't evaluated. But as you can see here, the top two columns, so this is T1 residual disease, well over 60% of patients only had T1 residual disease. So patients with T2 residual disease were about a quarter, T3 very rare. And I think that's a testament to the efficacy of disease when you look at the treatment, when you look at the burden of disease up front. And again, just under half of the patients were the axilla was pathologically negative, and the remainder either had N1 or N2 disease, very few with N3 disease. So quite significant downstaging, even though we didn't achieve PCR. I think the big headline, however, from this is that in the final analysis for invasive disease-free survival, we saw a 13.7 absolute percent reduction in the risk of recurrence with a hazard ratio of 0.54, clearly very statistically significant. There was no difference in any subgroup. The only one where you might say is that the 2+ with gene amplification compared to the 3+ IHC patients maybe didn't do quite so well. And I think that's plausible because we're relying on the trastuzumab to stick to the cancer for the emtansine to get to it. And if you've got a relatively low level of HER2 expression on the cells, it's going to do that less efficiently. This is a group of subgroups. And again, a really important point to show is that the benefit of trastuzumab emtansine is effectively irrespective of tumor burden after surgery. So it doesn't matter what the tumor burden is, the drug will be effective. And then this slightly complicated chart just shows invasive disease-free survival, any event in yellow and orange, it's with just trastuzumab. In pink and purple, it's trastuzumab emtansine, and the paler sections of the bars are the additional events between the primary and the final analysis. So you see a big difference in invasive disease-free survival events that I've shown you. As previously, most of those are distant recurrences or local regional recurrences, very few contralateral breast cancers and death without prior events. But interestingly, there's no impact on the number of CNS recurrences with the use of trastuzumab emtansine in the adjuvant setting. And then this is overall survival showing a nearly 5% delta at 7 years. So a big improvement in overall survival in this group of patients who are historically, we know, have a very poor prognosis. But interestingly, both OS curves are comfortably above 80% at 7 years. So we really have moved this field forward. And I'm not going to go into the safety. We all know that there were an excess of primarily thrombocytopenia and abnormal LFTs in the group receiving Kadcyla. So in any patient without PCR, we'd give Kadcyla, which we did to our patient. So it leaves the question, is there a role for primary surgery in HER2 positive early breast cancer? And I just want to show you the results of Sarah Tolaney's trial of APT, so weekly paclitaxel and trastuzumab. This was 12 weeks of weekly paclitaxel, an unrandomized trial. And it looked at small tumors. So most of these tumors were T1A and B, 42% were T1C, 9% were T2, and they could be up to 3 centimeters. 2/3 were ER positive, a third ER negative. And then this unrandomized study, you see a very, very low event rate with the use of the APT regimen. So at 7 years, 93.3 patients were free of a disease-free event, and a slightly higher number, 94%, compared to 90% in the ER positive versus the ER negative group. And this has been widely adapted in clinical practice for smaller tumors at relatively lower risk of recurrence. And again, in our practice, we will take ER positive tumors up to about 3 centimeters and ER negative tumors below 2 centimeters. And of course, the sub 2 centimeter tumors wouldn't be eligible in the UK for dual antibody therapy anyway. And then this is just a breakdown of the events. So any recurrence or death, 5.7%, local regional 1.2, contralateral breast cancer is 1.5, very, very small numbers of distant recurrences and very low numbers of deaths. So really a good regimen for the lower risk cancers. So putting it all together, if you've got a patient and you choose surgery up front and the tumor is 3 centimeters or less than 3 centimeters in ER positive and node negative, we would give them weekly Taxol Herceptin. The smaller ER negative ones, some of them we do, but in general, if the tumor is greater than 3 centimeters and node negative, we would give chemotherapy. Again, we tend to use EC followed by docetaxel with concurrent trastuzumab. And if you get a really nasty surprise and the tumor's node positive, then we'd give chemotherapy with pertuzumab and trastuzumab. And then in any tumor greater than 2 centimeters, we consider neoadjuvant chemotherapy. Any patient who's node positive, again, we consider neoadjuvant chemotherapy. But as I say, there are a few of the just over 2 centimeter ER positive ones, we go for surgery first. And then having given our induction chemotherapy, we have the decision point after surgery. And if there's never been any evidence of lymph node involvement, they get trastuzumab monotherapy, all given subcutaneously. If there's PCR and there has been evidence of lymph node involvement, we give pertuzumab and trastuzumab. And in patients who've not had PCR, regardless of how much or how little residual invasive disease there is, we offer them all trastuzumab and tansine. So the take-home message is that neoadjuvant chemotherapy has become the standard of care in hormone receptor positive early breast cancer, mostly to look for PCR and stratify post-operative treatments, as I've explained, and primary surgeries reserved for small cancers not meeting the reimbursement rules and where we really, really want to avoid the burden of chemotherapy. And that approach is essentially endorsed in any international guideline that you look at. So NCCN, AGO from Germany, that powerhouse of neoadjuvant studies, ESMO, St. Gallen, I could put more in. And this is the algorithm. This is based on the ESMO guidance. And at that point, I'm going to stop and thank you all for your attention.
Dr. Mark, thanks for the wonderful talk. We would request your presence in the panel as well. Thanks for it. Before moving on, we would have a certain question for the invites link as well for the audience. There would be a quiz rolled out. Please do attempt those. That will be useful for all of us. And for the next talk, we've seen the global experience now. It's time for the Indian perspective too. We have Dr. Satish Sethi with us, who is the Director of Clinical Trials at HCG Bangalore. Sir specializes in solid and blood cancers, pediatric lung and breast cancers. Sir has a vast experience, and sir is kind of working on a clinical trial of 150 patients across the HER2 positive breast cancer. We just had the initial results with us now, and sir would just show the initial experience and how FESGO has changed the life of patients as well. So over to you, Satish, sir.
Thank you, Dr. Weber. Thanks, Roche, for giving opportunity to talk on the Indian data. It is a real-world evidence I'm going to present. My slides are visible, Weber?
Yes, sir. Visible.
Yeah. Good evening, everyone. I think we heard from Professor Mark and Dr. Poonam Patil regarding the use of FESCO in our clinical practice and how that is become a part of our day-to-day of practice in HER2 positive breast cancer, especially in all aspects, in the adjuvant, in neoadjuvant and metastatic setting. I think it may be some of the slides are repetition. We have been known about HER2 overexpression has been expressed, overexpression seen in breast cancer and even gastric or gastroesophageal cancer. Definitely, they are associated with a poor prognostic factor, and also it is one of the predictive marker when you are dealing with these two cancer. Even it holds good for in other cancer also. HER2 overexpression associated with a high proliferative index and associated with the increased risk of recurrence, and histologically they had a poor prognosis. In the absence of target therapy, definitely they are associated with a shorter disease-free survival rate. OS also it's going to be less, shorter period. Definitely that we have seen that trastuzumab revolutionized the treatment of HER2 positive breast cancer, transforming the poor prognostic subtype into the effective target therapy. It has become improved the survival rate, and also later add-on therapy with a double HER2 therapy, and we have a drug conjugate, and you are having even other oral TKs and various the evolution of HER2 positive breast cancer is there. Still, a lot of unmet need is exist in the treatment of HER2 positive breast cancer. This is a slide like how we deal day to day the practice of HER2 positive breast cancer with the help of MDT, surgical oncologist and pathologist and radiation oncologist and medical oncologist with all other allied services are required to deal with the dealing with the HER2 positive breast cancer. It can be in the neo-urgent. We have heard from Professor Mark in depth. I'm not going to explain in detail. HER2 positive, like we take into neo-urgent, like double HER2 therapy or single HER2 based on the size criteria, node positivity, and later we'll try to analyze the after the surgery pathological CR rate, pathological CR, how it is achieved or not. Based on that, if any residual disease, we may go with a drug conjugate with TDM1 based on the Catherine study. And also adjuvant, if even if you see that adjuvant already patient underwent breast cancer post surgery, nodes positive, definitely that double HER2 is going to be standard of practice. Otherwise, we may go with the single HER2 transformer based chemotherapy. We heard from Dr. Poonam Patil like how difficult to use when you use the combination of pertuzumab and trastuzumab when we are going for using IV. The IV preparation, we know that is well established from the various studies, like may present in a few future study, and we heard from Dr. Professor Mark. But challenges we see with the IV preparation of pertuzumab, trastuzumab with longer IV infusion, because pertuzumab we have to give first, we have to observe, then again trastuzumab, then later we have to go like chemotherapy in initial period, later maybe hormone therapy. It is a very longer time of infusion. Patient has to stay in the hospital for a longer period. It makes a overburden to the way the patient is treating undergoing in the clinic or in the daycare center. It can be in a bigger hospital. Next is other challenges about the resource utilization. It taking a lot of preparation of time for IV preparation, infusion, and also resource utilization definitely is going to have an increase in the cost of therapy. Next is like not easy to give administration of IV. I think we heard from Poonam Patil madam that that's difficult to access the venous axis because of the venous axis not easy. You can get easily extravasation with a chemo drug, and access to like a prolonged IV infusion is not easy. And also like maintaining indwelling catheter also not easy. We may go for a chemoport insertion, like it may associate a lot of complication in the form of risk of infection, increasing the cost of the therapy, and also thrombosis and eventually the discomfort during the treatment. And also like some of the patient definitely associated with the established IV access can definitely is going to be burden some of the patient in a poor venous access. Not easy, even though that we might use a peripheral line, it's not easy to deal with the IV therapy. We heard from Professor Mark, like it has been double HER2 therapy, trastuzumab and pertuzumab, like Neosphere like study in the neoadjuvant setting. You can see here 4-arm study, trastuzumab and taxane based treatment, PHT, that is a pertuzumab trastuzumab based treatment, and only the monoclonal antibody and pertuzumab trastuzumab. You have seen this neoadjuvant treatment followed by surgery definitely shown this improvement in the pathological CR rate when you're adding the double or two combination treatment to the trastuzumab and chemo based treatment. And it can, irrespective of the nodal status, hormone receptor positive also and hormone receptor negative also definitely is shown in the improvement in the pathological CR rate. And definitely not only the pathological CR rate, and definitely is definitely improve the DFS rate, disease-free survival rate in all the arms intended to treat the population. You can see the 5-year DFS rate, like in the various subgroup. You can see by adding double to that the pertuzumab, trastuzumab, definitely improvement in the disease-free survival rate when compared to the other arms. The other neoadjuvant study, that is a trifina study, definitely is improve the pathological CR rate by adding the trastuzumab, pertuzumab when to the standard chemo-based chemotherapy. It can be anthracycline-based treatment, anthracycline and taxane for the sequential therapy, or it can be the non-anthracycline-based treatment. You can see here, irrespective of this anthracycline versus non-anthracycline-based treatment, double R2 definitely improves the pathological CR rate. Coming to the adjuvant treatment, you can see we heard from Professor Mark. It is extended. The follow-up also presented even more than 11 years also. It has definitely shown a consistent improvement in the invasive disease feral rate in a node positive subgroup. And at the end of 8 years, even 11 years also definitely showing the decrease in the risk of definitely reduce the risk of reduction of recurrence, and also improvement in the delta of 5% in invasive disease for all rate. Coming to the OS data, definitely it is shown in the improvement in a 17% reduction of death by addition of double pertuzumab to the trastuzumab based treatment, in especially in the node positive cases. Coming to the metastatic setting, this is one of the Cleopatra study. It is a landmark study. It is based on that one. We have changed our practice from many years back. You can see here adding the pertuzumab to the standard older treatment of trastuzumab based chemotherapy. You can see here the invasive like a PFS. You can see delta of increase in more than 6.1 month. The median PFS is 18.7 months when compared to the 12.4 months. Definitely hazard ratio was statistically significant, that is 0.69. It has changed our routine practice in all HER2 positive metastatic breast cancer. Coming to the OS data of this Cleopatra study, you can see median OS of 57.1 month compared to the 40.8 months when going for only single HER2 based chemotherapy regimen. And hazard ratio was significant here, 0.69. You can see here delta of improvement of 15.7 month improvement by addition of pertuzumab to the older standard treatment, what we supposed to treat 10 years back, trastuzumab based chemotherapy. Coming to our Indian data, it is a comparative analysis of subcutaneous dual HER2 blockade versus the conventional treatment, what we used to do, the treatment conventional real world treatment of HER2 positive breast cancer. It is a multicentric observational retrospective study. And here, we try to use the real world evidence of use of subcutaneous the FESGO versus the standard treatment. We used to use the IV preparation of pertuzumab, trastuzumab, and also HER2 based treatment in a HER2 positive breast cancer. This is a study design, multicentric retrospective observation study of 150 HER2 positive breast cancer from the 5 sites of our India. It is a 3-arm study, 3 cohort study groups are there. Arm A is patient those are treated with the subcutaneous preparation, that is FSGO, in combination with the chemotherapy. Arm B is patient those are treated with a standard IV double HER2 therapy, that is pertuzumab and trastuzumab based chemotherapy in combination with the chemotherapy. Arm C is patient those are treated with a trastuzumab alone in along with the combination with the chemotherapy. These are 3 arms. And cohort of 3 cohort in the neoadjuvant setting. Cohort 1, cohort 2 is adjuvant HER2 positive breast cancer. Cohort 3 is a metastatic HER2 positive breast cancer. Objective is to seek the evaluate and compare the real world outcome of this use of FESGO versus the IV double HER2, that pertuzumab trastuzumab based chemotherapy or trastuzumab based chemotherapy alone in the real world clinical settings, what we are treating in a HER2 positive breast cancer from India. The primary endpoint is to see the pathological CR in arm A, arm B, arm C in the cohort 1. This is a neoadjuvant setting. 2-year DFS disease-free survival rate in arm A, arm B, and arm C in the cohort 2, and overall response rate in 2-year PFS rate and 2-year OS rate in arm cohort 3 in all the 3 arms. Secondary endpoint is to correlation of weight, body weight to the outcome, and also efficacy of chemotherapy backbone on the outcome of the patients. This is a interim analysis I'm presenting, like because we are not completed 2 years also some of the patients. So that's why like the data is it appears to be like a short follow. You can see here the arm A in the cohort 1 where you can see the pathological CR is almost 37%, cohort B is 42%, cohorts the arm C is 30.4%. Here the pathological CR rate in the various arms is the only single or two IV preparation. Here the double or two IV preparation is the subcutaneous form. Overall response rate in the cohort 3 almost 80% response rate is there, and 70%, 70.6% in the arm B. Arm C is at 58.3% in the single or two. That is a can say advantage almost 21.7% an additional advantage when compared to the IV preparation of a trastuzumab alone. And you can see the treatment duration. It is almost you can complete in 15 minutes in the double or two subcutaneous preparation. Here is almost taking 90 minutes median time, and here is a arm C is almost 60 minutes time. Here it is almost advantage like 5 times faster you can administer in a subcutaneous preparation compared to the IV preparation. This is this initial you can see the slight difference in the because of the initial reflection as the patient numbers are small, still data is maturing. We are trying to have a follow-up of these patients. Key insights of this one, the dual HER2 blockade, that is a subcutaneous preparation or IV, improves the pathological CR rate is almost by 25% versus the trastuzumab alone. FESGO shows that comparable efficacy to the IV double HER2 therapy in the resource optimization, and weight-based efficacy correlation FESGO consistent across all BMA ranges. It's even overweight patient also we try to have a same fixed preparation, definitely is helping in our patients. Coming to the neoadjuvant cohort 1 patients, pathological CR, you can see here the pathological CR of the 3 different preparations. Subcutaneous preparation is almost 37%. IV preparation is almost 43%. Trastuzumab alone is 30.4% was there. This is the what are the numbers, what percentage, what we are taking. Clinical implication, this dual HER2 blockade, whether it's a IV or FESGO, the subcutaneous preparation increases the pathological CR rate is almost like nearing to 37 to 44% versus the monotherapy is almost aligned with the almost global trial of a Neosphere study, that is a 45%, 45.8% pathological CR in the dual blockade. Pathological CR advantage, definitely it improves the predicts the long-term survival rate based on the meta-analysis what is published. FESCO delivers the comparable efficacy of to the IV dual therapy. That's why it's become a more advantageous to easy to convenience to administer this drug subcutaneous preparation. And coming to the metastatic setting of cohort 3, the FESCO leads like you can see the overall response rate FESCO. You can see 80% response rate with FESCO subcutaneous preparation. Highest response rate is there. IV preparation is 70.6% is there. Single the trastuzumab IV preparation is of 58.3% is this is a baseline basic baseline clinical benefit of and with the trastuzumab with the chemotherapy benefit. Highlight of this one, the cohort 3, the metastatic the HER2 positive patient. You can see the overall response rate. Like you can see that almost 17 cycles, many patients are completed. They're ongoing with the continuation of double HER2 therapy. Dual blockade definitely reduces the progression of disease almost like 38%. Hazard ratio was 0.62 in this cohort patient. What we have almost 26 patients. And safety and tolerability of this subcutaneous preparation, you can see here, like compared to the other preparations, IV double HER2 or single HER2 blockade with the trastuzumab alone. Diarrhea, you can see here, like IV subcutaneous preparation is slightly lesser compared to the IV preparation, and with a slightly more compared to the single HER2 blockade. Neutropenia, like it is less here, that it may not be the double HER2 or single HER2 is not a decision factor. Here maybe the chemotherapy factor. And infusion reactions definitely is very less with the subcutaneous preparation when compared to the IV preparation of double HER2 versus single HER2. Highlights of this one, safety tolerability here is a 78% reduction in the infusion reaction with the subcutaneous preparation when compared to the double HER2 IV. and there is no safety signals when compared with the standard the older study. Coming to the conclusion from my talk, FESGO provides the benefit in the cost, time, and reduction in the patient healthcare professional burden. Shorter administration of time is of almost like within 10 to 15 minutes you can finish. That is a initial loading dose maybe slightly higher time. Maybe that is the median time is almost within 10 minutes you can finish. Observation period of almost within 15 to 30 minutes we can finish. It reduces the burden to the patient and caregivers and providers, and even to the hospital and daycare centers. And FESGO is less invasive administration, single subcutaneous injection compared to the IV preparation of two infusion and observation period. Many clinicians, I don't know their practice gap between the preparations. And fixed dose preparation may help to reduce the risk of dosing error, because fixed dose is like irrespective of weight, we can go, it is easy. The loading dose, if you finish, then later the same preparations is go in the throughout the cycle, throughout the patient life. In a metastasis setting, in adjuvant setting is neoadjuvant setting is a fixed number of cycles. Definitely reduce the drug wastage and increase the availability of nursing and pharmacological staff. What are the errors and tasks involved with the healthcare providers? Reduce the time required for the drug preparation and administration of a drug with the substance preparation versus the IV preparation. Definitely, this potentially it gives the more burden on the infusions to infusion centers, and also maybe associated with infusion reactions also. There is no safety signals associated with the observation with the switching from IV to subcutaneous preparation, vice versa. We have done few cases that no any safety signal, we can easily switch from the IV to subcutaneous the preparation also. Thank you. I'll stop here. Like I think we can discuss any questions are there, and I'll hand over to the next speaker.
Thank you so much, Satish, sir. It's
Thank you.
heartening to see that FESGO is slowly transforming the patient care and healthcare resource utilization overall as well. And with, of course, the promise of effectiveness and safety. For the next talk, I would like to invite Dr. Krishna Prasad, who's the Chief Medical Oncologist at MIO Bangalore. He received his UG and PG from Bangalore and Manipal University respectively. He has done his DM from medical oncology from prestigious Adyar Cancer Hospital. Sir looks so dashing and young, but I think he is the first medical oncologist of Bangalore and has a vast experience across chemotherapy, immunotherapy, and targeted therapies as well. Sir, I would request you to please take the session, and I would also request Poonam ma'am if she can be a part of the panel as well, and of course Dr. Mark as well.
Yeah, thank you, Rosh, for this opportunity. After some wonderful talks, let's just quickly discuss the nuances of treatment of HER2 positive early breast cancer. So we'll take a 45-year-old premenopausal woman presenting to the breast clinic with a growing mass in the left breast, which she noticed for 2 months, and the mass has become a little painful. On examination, it was a 3.5 centimeter mass in the left breast with no overlying skin changes or nipple discharge, a firm enlarged axillary lymph node in the left axilla. This is the PET CT. You can see that there is a 4.8 centimeter lesion with SUV of 3.8. Some axillary lymph nodes are there, and underwent a biopsy. Biopsy was HER2 positive, ER positive, PR negative. FNAC of the axillary lymph node is also positive. So this is a T2N1M0 ER positive and HER2 positive breast cancer. So let's start with Dr. Kunal Jain. Sir, in your practice, what do you do when such a patient comes to you?
Yeah, good evening. So please quickly remind me the age of the patient also.
42, 43,
42.
yeah.
Okay. So this is a patient who has node positive, HER2 positive early breast cancer. And this patient will qualify and will be advised neoadjuvant chemotherapy at our center. And discussion about breast conserving surgery or mastectomy obviously will be done. But since it is a smaller lesion, we would be inclined towards breast conserving. So a clip insertion. And then to proceed with dual anti-HER2 targeted therapy with the taxane and carboplatin. I am generally tending to omit anthracyclines in such patients.
Fair enough. Dr. Parikshit, would that be the same thing with you, or would you have a different idea?
No, that would roughly be the same as, what I would do. The only thing, which I'd like to add is that, I would prefer a dual HER2 blockade for this patient. Along with the chemotherapy backbone consisting of a anthracycline-based regimen.
Dr. Vikas, such patients, what percentage of such patients actually undergo surgery by the surgeon and then come to you? Vikas, are you there? Dr. Muzamil, sir, in your practice, what percentage of patients are you able to give neoadjuvant therapy in such situations? How many of them actually receive dual HER2 and how many receive only trastuzumab? And what percentage actually undergo surgery and come to you?
So again, Krishna, it's all depend upon what kind of an institute you are practicing. So we have a DMG. So when you have a breast specific unit, you're going to in a tertiary care center, your scenario is going to be different. So we almost say more than 90% of these patients will come to us. In fact, I will say 100% will come to us before surgery, which is a great thing. And in clinical practice, because of financial constraint, I will say around 40 to 50% of my patient will get a dual anti-HER2 blockade. Again, this is not true across the board. In smaller centers, this percentage may fall to 15-20% will afford a dual blockade. But at my center, it is around 50% at least where they get dual HER2 blockade.
Fair enough. So I think many of us would want to give dual HER2 blockade with neoadjuvant chemotherapy, and a small percentage we are able to do it. In quite a few percentage of patients, we are able to do single agent trastuzumab with the chemo, and a small percentage actually end up with us after surgery. So this is a question which I think all of us want to ask. I think first we'll ask Dr. Mark in his practice. Does he use anthracyclines? If so, how does he select patients for anthracyclines?
So the answer to that is yes. In the overwhelming majority, we do give an anthracycline. And partly that's historical from being an investigating site in Berenice. I think the other really important thing is that a lot of the anxiety about using anthracyclines in anti-HER2 or in HER2 positive cancers comes from the original data when doxorubicin was combined with trastuzumab. And all of our anthracycline use is epirubicin, which is much less cardiotoxic than doxorubicin. So we would give an anthracycline for the majority of patients. The exception would be very occasionally in a locally advanced patients on the borderline of operability, we would use TCHP up front to get the anti-HER2 drugs in first. But I think it's interesting that an important consideration in if economic concerns are in there is that we know from Dennis Slayman's data many, many years ago that a lot of patients are very, very sensitive to anthracyclines if they've got HER2 positive disease. And if you think about it, if you're using a block sequential, you're only going to give 3 or 4 dual antibody therapy up front. Whereas if you use TCHP, you're probably going to give 6 cycles of H and P. So I think if you're cash constrained, it may be more efficient to use an anthracycline containing regimen. But we certainly do in our centre for the majority. I know across the UK there's a pretty even split between people using TCHP versus ECTPH. I think the other one is, in our experience, TCHP is definitely more toxic. And if you're worried about toxicity, then using the anthracycline first and then a taxane with dual antibody is probably going to cause less in the way of side effects.
Fair enough points. I think that's a very good perspective. Dr. Chandrakant, in your practice, what do you do?
So, sir, if a patient can afford the dual HER2, we are avoiding anthracyclines. So we are using taxane, platinum, and dual HER2 in the neoadjuvant setting. Again, the duration of this is something around like up to 6 cycles of TCHP. You know, that up to that we give neoadjuvant therapy, and we are avoiding anthracyclines.
Okay, Dr. Vikas, in your practice, do you use anthracyclines or not? I think Vikas is not joined, so we will go back to Dr. Kunal Jain. Sir, in your practice, I think you wanted to ask this question also to Dr. Mark. What do you do?
As I mentioned earlier for the case that we were discussing also, so if affordability is not an issue, I would consider giving dual anti-HER2 with the TC, and obviously if cost is a constraint and maybe another subset where it is strongly ER positive, and like earlier Dr. Mark was mentioning HER2 2+ and then coming reflexly positive on FISH, maybe the cases where we may be I may be using anthracycline with 4 cycles of anti-HER2.
Yeah, I think even in India, there are quite a few of us who are still using anthracyclines, and many a times we are trying to move away from it to TCHP. Dr. Mark, I want your opinion on avoiding carboplatin. What is the actual role of carboplatin in the TCHP, or can it be just, THP?
So I think the rationale for using carboplatin comes from the preclinical data from the very early days. So all of that data is effectively more than 20 years ago, and we've forgotten about it. And there's some American data come through saying you may not need the carboplatin, but are we really going to be happy with giving monotherapy chemotherapy, particularly when you look at the evolution of the studies? And yes, it was only 4 cycles, but Luca Gianni's, you only got a 46% PCR rate with 4 cycles of docetaxel, pertuzumab, trastuzumab. So I do slightly worry about the veracity of some of these small number non-inferiority studies. And I think if you're going to treat patients, are you really going to rely on chemotherapy monotherapy unless you've got a very good marker? And I think if you can, do serial PETs and they're ER positive and you can micromanage them, then maybe there are some patients where you can omit not only the dual or the extra elements of chemotherapy, but that's very labor intensive, big center, multiple imaging, and I don't know that it's ready for prime time. But I'm very wary about going too far with de-escalation. And I think the other issue about it is that if you do give lesser chemotherapy up front, and this has really made me think about it recently, a patient I'd seen when I was thinking, well, she should have surgery first, we should give her weekly Taxol Herceptin adjuvantly if we don't get any nasty surprises on the surgery. And she went off to see a professor in Harley Street who said, oh, well, we'll just give her weekly Taxol Herceptin first and see how she does. But if you don't optimize your neoadjuvant treatment, you run the risk of not getting PCR, and then you have to dose escalate your adjuvant treatment. So if you're going to go neoadjuvant, you've got to have a different hat on. And your hat is, I am doing everything I can to achieve PCR in this patient. And therefore, you've got to go at it with chemotherapy, because the implication of not PCR is that you're going to end up giving a year of adjuvant Kadcyla, which is going to be a load more toxic and massively more expensive than giving just antibody therapy, particularly if it's just trastuzumab. So I think that while we are keen to de-escalate, I think you've got to pick your space. And I think the space is post-surgery, not pre-surgery, because I think we think completely differently about neoadjuvantly and trying to get the treatment in, trying to get the tumor shrunk, trying to get the PCR. Adjuvant, we're much more relaxed about it because we're just managing risk.
Fair points, I think. Dr. Parikshit, in your practice, what percentage of patients get a dual anti-HER2? And have you changed to subcutaneous? And what do you think the subcutaneous preparation has done?
Yeah. So in my practice, approximately a quarter, or I can say maximum up to one third of the patients receive, dual anti HER2, blockade. And mainly, your question regarding, IV versus, subcutaneous, I would prefer a subcutaneous formulation. But again, when cost is a constraint, I usually put the patients on, IV. Now, coming to subcutaneous, it has a tremendous advantage in that it reduces, the bed occupancy time, especially like at centers with, busy daycare centers, busy hospitals, which have, acute bed shortages. It, really helps us in, freeing up our chemotherapy daycare beds on time.
Fair enough. Chandrakant, your experience with subcutaneous?
Right. So we have good data, as Professor presented, that the pathological complete responses are similar to IV formulation. So we are using subcutaneous formulations, and as stated, shorter duration of hospital stay, quicker, and it is very easy to give. So it has that hyaluronidase component in it, so it can be easily doable. So we're using liberally subcutaneous formulations even in the neoadjuvant setting.
Dr. Muzammil, your take on this, and also your quick comment on, are you worried if somebody is very obese?
Yeah. So I think in my practice, since the availability of IV now at a cheaper rate, it is around say 50-50 for me, because still a lot of patients do prefer subcute, and I personally will prefer subcute if the patient can afford, for obvious reasons what Parishit and already Chandrakant has said. So it's a easy drug to use. Patients are very comfortable. We are very comfortable, and in my, I will just differ what, of course, the very early data from Satish side, but then what I have seen, pass CR rate is what I never expected. It's around 85 to 90%, whatever, numbers we have done with the doublet I'm talking about, not specifically with the subcute. That we have not yet analyzed whether there's a difference in the IV versus the subcute preparation of the dual, but it is around 85 to 90, which is really high than what even the international data or the clinical trial mentioned. Regarding obesity, yes. So our patients, unfortunately, many whom we give are not obese actually. So diarrhea is a major concern. Again, diarrhea in Satish thing was less actually, and I was surprised that in his data it's too early. But even in the single agent IV trastuzumab, there was significant diarrhea, which we don't see so much actually. It was almost 15%, and the doublet was 18. So again, I'm not so sure. But in my clinical practice, the diarrhea with a doublet, especially the IV preparation, is in the tune of 50 to 60% at least. So, and it is troublesome diarrhea in the initial 2-3 cycles, but we have learned to manage it. Obesity does play a role because this all fixed drug combinations will be always an issue. So you have to choose, but unfortunately, the subcute is a fixed dose currently.
Yeah, Dr. Kunal, your thoughts on the subcutaneous preparation, the diarrhea aspect, as well as the use in obese patients.
I think both the categories, both the underweight and obese, there were some concerns from the Federica study, but again, the numbers, both groups were too small. And what has been our conventional learning to use a particular drug on weight-based formulation, and now suddenly we are switching to a fixed dose. Unlearning those things and doing things differently also is a challenge. But having said that, in both categories, both are very small numbers, even in clinical practice, I would say. And we are still using both the formulations, IV as well as subcutaneous, in this category, and haven't yet experienced any significant problem. But diarrhea definitely is a major problem. And in addition to diarrhea, also patients have asymptomatic kind of leukopenia and some neutropenia, which is going on with dual anti-HER2, which is not the problem with the trastuzumab. I don't know about others' experience, but counts in the range of about 3,000, 2,800, which continue in that range. But again, patients remain asymptomatic.
Professor Mark, your thoughts on this? Are you concerned if the weight is very low or very high? And do you switch to IV in such patients, or do you think that these numbers are too small?
So I think I don't think there are two very important considerations in this. The first one is that pertuzumab is being flat dosed anyway, so you're not switching from a variable dose IV to a fixed dose subcut. It's always flat dosed. So adding in pertuzumab, I don't think is a question. And then there's much more information for that reason on Herceptin subcut. So more than a decade ago now, we took part in a lot of the developmental work of the subcutaneous trastuzumab. And there's a pharmacologist called Bert Lum who works for Genentech. And Bert's looked at this. And there's an inverse relationship between rate of trastuzumab metabolism and body weight. So smaller people tend to metabolize the drug quicker. And if you then look at levels in the plasma, you don't see a difference in plasma levels based on weight. So the small patients and the larger patients seem to have very similar serum C trough levels at cycle 8. So on the basis of the translation of variable dose IV trastuzumab into subcut, I don't have any concerns around Phesgo. And I think, as you say, these numbers are tiny. And you look at this underweight patients, well, yeah, there were only 3 who received IV and they all got PCR. So what? You would expect that relationship to be the other way around, actually, because the underweight patients on subcut are getting a higher dose of trastuzumab at least. So I don't worry about it. And we were a very early adopter of subcut Herceptin, and we've now used it for, I think, 12 or 13 years. And it's not an issue even considering IV in our practice now. We just don't do it. And if we wanted to, it would be very difficult to repatriate all of those patients who are getting subcut, and they're getting it in peripheral clinics. We do it in outpatients. We do it in a pharmacy away from the main hospital. And we would really struggle to bring all of those patients back onto the day unit for IV therapies.
Fair enough. So I think this has already been discussed. We know that there is significant time savings, bed savings for the hospital, as well as I think patients generally would prefer a shorter, quicker infusion rather than a prolonged IV access. So this patient received 6 cycles of TCHP and underwent surgery. This was the response in terms of a PET CT. PET CT virtually did not show anything. So even though there is a lot of data to say that PET CT is not sensitive enough, what has your experience been, Dr. Muzammil? Does it correlate with what you see PET CR, or many a times is it totally different? Dr. Muzammil, are you there?
Yeah, I'm very much there. So I just missed the question.
The question is, we are doing PET CTs now, looking at the response. Do you think that the response correlates with the PCR rates, or it's not been the same?
No, it's not the same, honestly, which is true for most of the solid tumors. So if I see a rough, I'm not. So if I say that if there's 100 PET scan which is showing a CR, say patch CR will be seen around, say, 70% or so.
Fair enough, fair enough. So at this point of time, I think we'll just ask Professor, any experience with HER2DX? Has he started using it? Is it available?
It's not funded in the UK, so we can't use it.
So Dr. Vikas, if you are there, any thoughts on this? Otherwise, Dr. Kunal Jain.
So I also totally agree that not much experience, but definitely 3 important points. First, we always do a PET scan before going for the surgery, as it's a surrogate, whereas those who have achieved a radiological response are those who are getting a pathological response at the end of the day. Also, correlating is getting an MRI done, because these are early breast cancers. Sometime new nodules can tend to pick up, and that's where we tend to lose on a local failure. And third is something which I always love is about FESGO is once the patient gets the new adjuvant and the surgery done, the compliance of the patient especially decreases in the adjuvant situations. And that's where the FESGO plays a very important role, because coming out, it takes hardly 15-20 minutes. They don't get their needle pricks, and most of them tend to complete the adjuvant, the whole cycles, as compared to when we switch to an IV version for that.
Yeah, fair enough. Dr. Kunal, in your practice, when do you restart FESGO? And if you're restarting FESGO, do you ever think about doing a reloading again?
Yeah, as Dr. Mark also mentioned, so we generally tend to give a dose of anti-HER2 just prior to the surgery, maybe a week before that. And then that gives us a window to continue the same. As of trastuzumab, from what we know, that after 4 weeks, we have to do the loading dose again. So if that is the case, usually we have to do, but for FESGO, I haven't done any reloading for the patients.
Dr. Mark, your practice, do you always try to give one more FESGO before surgery and then continue it so that there's no gap?
Yeah, so a lot of the trials it wasn't allowed. So in Berenice it wasn't allowed, but in routine practice, we complete the cytotoxic component of treatment. We give one FESGO 3 weeks later, and we try and persuade our surgeons to operate kind of within 7 days of that dose of FESGO. And then the patients are all discussed in the breast MDT meeting, basically 2 weeks after surgery. So that takes us to kind of week 3. And it usually takes us an extra week to see them, to have the discussion about where they're going in the adjuvant setting and to then continue their adjuvant therapy. So we usually have a 4, sometimes 5 week gap between the last FESGO before surgery and the first whatever adjuvant treatment they're going to get. If it's more than 6 weeks, we reload with FESGO. If it's less than 6 weeks, then we don't, and that's consistent with the label. Obviously, trastuzumab, you don't need to reload if you're using subcut formulation. And Kadcyla, they're starting with a clean slate.
Fair enough. So, in your practice, Parikshit, what percentage of patients actually go into PATH CR? And if they don't, what percentage are you able to change to Kadcyla?
Yeah. So in my practice, I can say that approximately 60 to 70% of them, they go to, go into a PATH CR. And in case for the patients who do not achieve a PATH CR, I can safely say that almost all my patients are on, Kadcyla.
Fair enough. Chandrakant, in your practice, when do you consider single agent trastuzumab as maintenance?
Right, sir. So, first is upfront surgery where it's a T2N0 tumor. There we use only trastuzumab. Then in those patients who have achieved a PATH CR, post neoadjuvant, we would continue both HER2 and TRAS2 for a year. But in those patients who cannot afford at all, in them we consider trastuzumab alone.
Fair enough. Dr. Vikas, when do you consider single agent trastuzumab during maintenance? I mean, during adjuvant, post neoadjuvant? Vikas, are you there? Dr. Kunal, in your practice post neoadjuvant therapy, how many of them do you actually consider for single agent trastuzumab if you have given a dual upfront?
Yeah, that number would be small because the most of the patients that we are giving neoadjuvant to, majority of them are node positive to begin with. But yes, if there is a true node negative, maybe with a larger tumor where we are giving neoadjuvant chemo with dual anti-HER2 and there is complete path response with no evidence of disease or even any response kind of thing in the nodes, those may be the candidates where I may be tempted to use single agent if there is a cost constraint. And even in those patients who are willing to continue dual agents, I would maybe continue.
Fair enough. So I think now the data is pretty clear. Somebody is especially node positive, you would definitely continue. So I think this patient received and completed 1 year of FESGO. So Dr. Vikas, if you are there, your final thoughts on FESGO and where you see it moving forward? Vikas, you're not there. Dr. Kunal, sir, your final thoughts?
I think it has really changed how we are understanding and also trying to treat patients also from the conventional IV form to subcutaneous. And I think with other treatment options also, we are kind of exploring those options like in myeloma and other, just to give an example, which is making more convenient for the patients. The only challenge remains the cost. So I think if that is addressed in much better manner, I think it will have a much wider spectrum of usage.
Fair enough. Parikshit, your final thoughts on FESGO?
Oh, sir, it's really helped most of the patients, especially when it comes to patient compliance, because especially in the adjuvant or in the metastatic settings, if you can say, patients are not very comfortable getting repeatedly pricked and getting IV cannulas inserted. So I think it's been a real game changer for these patients.
Fair enough. Dr. Muzammil, sir, your thoughts? Dr. Muzammil, your final thoughts on FESGO? Dr. Chandrakant?
Right. So the advantage of FESGO is you're getting both pertuzumab and trastuzumab, which is an innovator. This is one. And secondly, the patient satisfaction levels are higher if I use FESGO because of shorter duration of administration. And thirdly, you have good data of pathological complete response equivalent to IV formulation. These can be easily used. So I think if a patient is eligible for dual HER2, FESGO should be put in the front cart.
Yeah. Dr. Mark, your final thoughts, and I would like to know about the diarrhea with FESGO. Does it tend to happen along with the chemotherapy or even when you're using FESGO alone?
I think when it happens with chemotherapy, we think it's most likely to be docetaxel, and we dose reduce, and that usually solves the problem. There are a group of patients, however, who get it from the EGFR1 action of the pertuzumab in the combination, and on occasion we have to switch to trastuzumab monotherapy in that setting. From the point of view of final thoughts on FESGO, I think from a clinician perspective, it's equivalent. It does the same job. It has the same side effect profile, and it doesn't make a huge amount of difference to me whether I'm prescribing an IV or a subcut. I think where it wins hands down is for patient experience. And for patients, it's life-changing on a number of levels, mostly time, convenience, less pain. They're away from the chemotherapy day unit and the memory of the IV cytotoxic chemotherapy. And I think from that perspective, it's hugely advantageous. And as you've probably gleaned, we've been very involved in the development and always been enthusiastic, very early adopters. And our experience of subcutaneous anti-HER2 drugs has been universally positive.
Thank you, Professor. And I thank Roche for this opportunity and hand it over back to the organizers. Thank you.
Thank you, sir. Thank you so much. Poonam ma'am, any final thoughts from your side?
There's so much to. It has been an interesting session with Dr. Mark Verrill telling us about his experience, as well as Dr. Satish sharing what he has studied with his patients, and an interesting interactive panel discussion what Dr. Krishna Prasad had. And there is no doubt that trastuzumab was the first revolutionizing drug for HER2 positive breast cancers. Till then, we just knew that it is bad, bad, and bad. And it's only when trastuzumab came that we realized that there is something like targeted therapy for such an aggressive breast cancer, which may change the face of such patients. And then came pertuzumab, and then came Phesgo, which is easy to use, ready-to-use combination of trastuzumab, pertuzumab, which patients again prefer whenever they have taken the intravenous formulations, and they have also tried the subcutaneous. Almost 95% of them choose the subcutaneous formulation compared to the intravenous formulation. And I think everyone has said the same thing. So thank you very much, Rosh. I give you back the mic, Dr. Vaibhav.
Thank you, ma'am. Thank you so much. As we conclude the HER2 positive matters from control to cure, we extend our heartfelt thanks to all the participants and attendees for their time and engagement. A special note of gratitude goes to Dr. Mark Verrill for sharing valuable global insights, and to Dr. Poonam Patel, Dr. Satish Sethi, Dr. Krishna Prasad for their pivotal roles in leading today's scientific discussions. Our sincere thanks to all the esteemed panelists, Dr. Kunal Jain, Dr. Parishit Jayaprakash, Dr. M.B. Chandrakant, Dr. Mujamil Sheikh, and Dr. Vikas Talreja for their rich clinical perspectives. We look forward to such continued collaborations. Thank you once again, and good night to all of you.
Thank you so much, everyone. Good night. See you soon.
Thank
Good
you
night,
and good
good night.
night.